Get the key. All right, guys, let me unlock the building here. I got a couple knocked down on the door, and then we'll get started. All right, guys, so some clerical things before we get going too far. This Zoom link that you guys have, tonight will be the last night that it will be good. I will email out a new one to you. So just be aware of that. If you've got this saved, there'll be a new Zoom link coming out. The other thing worth mentioning is this puts us over halfway through the book. And some of these chapters should hopefully get moving a little faster that way too. So we should be on schedule to start our hands-on the middle of November. That way for you guys. I'll give you a heads up. I am going in for surgery on November 17th to get my ankle rebuilt. And I won't be able to walk on it for the first 3 weeks of your hands-on stuff. So we'll have Bambi and Joanne helping with that. And then I'll step into it after that. Any other questions that way for me? I don't. So the hands-on should, so we just asked what day are we going to start hands-on. So we're doing 3 chapters a week and we have 20 left. So what does that mean? 6 weeks. So it might be closer to the end of November. So some of these other shorter ones too, just to give you guys some heads up that way too, when we get into the 30s, they're really, really short. So we're probably going to try and shove 4 of them into one night.
When we start doing the hands-on, where's it going to be at?
So for you guys at the mine, I'm going to shut that off. For you guys at the mine, it will be at the mine site. It will be for day shift. It'll be the 3 hours immediately following day shift. For swing shift, it'll be the 3 hours immediately before swing shift. And graveyards, it will be the same, the 3 hours immediately before swing shift, or graveyard, excuse me.
So right, basically right now, for like 6 to 9.
Yeah. If we're still moving the wall, we'll have to work around that. I'm
Right.
hoping by the time we're done with this, we're back to our normal schedule and the wall moves over. But yeah,
Don't hold your breath.
no, not after I went down on the Longo face last night. I would hold your breath.
Yeah, I was down there last night too. It was looking fun.
Right. I just hope that head gate stays up. So yeah, that's the plan for it now. For you guys on the Sanfleet side, it will be Wednesday night, so it will switch. Instead of Thursday nights, it will be Wednesday nights here in Wales at the new fire station. So it's the new white building just straight across the street from here. So we'll do it at the fire station instead of City Hall. That way we can leave a lot of the training stuff there. So you guys on the price side, you're more than welcome to come over on Wednesday nights. It'll be 6 to 9 on Wednesday nights over there. Any other questions as we move forward? Most of you guys that are on and been doing the Zoom have been doing your homework and stuff. I greatly appreciate that. Encourage those that you see that you know are taking the class to keep up on it too, because we have a few that need to get moving on it. Any questions or concerns that you guys have had with My Brady Labs? Have we worked through most of those kinks now?
I have a question.
Okay, shoot.
Can you hear me?
Yeah.
On some of the chapters, there's like a scenario at the end. But after the test, and I have been bombing those really, really bad. I'm not doing very well on them. So is that part of the grade? And am I going to fail if I keep doing bad on those? Is it something I can wait until the end of class, like when we've done hands-on?
We can go through them. So I'll open those up. It's the critical decision making or the critical decisions or critical thinking cases. I can't remember what the words I'm as in this edition.
Yeah.
Those I'll open up for the third time or 3 times and you can do it. So you will need to get 80 on those as well.
I do have to get an 80. Oh
What's
gosh.
that?
I have to get an 80 on those.
You'll do it, Jessica. I have faith in you. I promise you.
Well, don't look at the scores I already got, because then you won't have any face left. They're really bad.
No,
Okay.
you'll be good. We'll be good.
All right, thanks.
You're welcome.
But
Any
those
other?
can wait, right? Like I've been skipping them for now.
Yeah, they're not due till the end.
Okay, thanks.
Yep. And I would probably encourage you guys. I mean, if you want to do them as you go through, you can, but it'll make a lot more sense if you do them when we're done with the class, because it's trying to tie it all together.
Right, that's what I'm hoping.
So,
Thanks.
yep. Any other questions, guys? All right, so if not, we'll go ahead and get into tonight's chapter. So tonight's goal, we're going to try and cover 22, 23, and 24 tonight and move through that. So this is more of our specific emergencies. I was not here last class, obviously. Do you guys have any questions as Bambi went through cardiac and respiratory emergencies? Because they are a fairly big part of the test material too. Any questions on those guys from Zoom either? And you guys in Zoom are going to start getting picked on a lot more now that I have audio working, so just be prepared for that too. All right, if not, here we go. So chapter 22, diabetic emergencies and altered mental status. A lot of the times as we start talking on this, they tie on the altered mental status to diabetes just because that's usually what it'll do, but there's also a lot of things that I want to caution you as we start talking on these, not to get into the rabbit hole of every altered LOC is a diabetic island. My computer's gonna die if I don't plug that in. All right. So we're going to cover some of the pathophysiology of it, the diabetes, and then other causes too. So we'll hit into it a lot. And then the treatment of them too. Anyway, when we get into that, there's some different treats that I want to teach you guys, or tricks, excuse me. So normally, as you guys are looking at this, like we always talk, I don't care a lot of the times if you know specifically what abnormal is, as long as you know what normal is. So the normal pathophysiology of consciousness is regulated by the reticular activating system, or RAS. And that's what sets your sleep pattern. So for you guys at the mine, when you go from days to graves to days to graves, that's what you're messing with a lot of the times, is that your body's ability to set it's responsible for staying awake and sleeping and all that, switching from one to the other, really throws that off and can take a few days to get used to. It has the brain tissue, has the basic requirements, meaning it needs oxygen, it needs glucose to nourish the brain, and then also water to hydrate the brain tissue. So some altered mental status can be caused by some deficiency in the REA requirements, meaning so trauma, infection. So a lot of the times when you see somebody with a head injury, they have a hard time regulating their sleep and awake patterns because of the trauma that's caused there. Also infections are really hard to it, because not necessarily the infection all the time, but the fever that comes with it. And then the long-term effects that go with that. Chemical toxins can be, most of the time when we talk chemical toxins with it, we're talking medications of some kind. So a lot of your medications, they'll tell you to take it at night, or, before bedtime, or when you wake up, just because of its effect on this and how it, so anyway, some deficiencies if they take the medications wrong, the wrong time of day, overdose, or too much of them, intentional, or whether it's intentional or not, can cause that too. Primary brain problems. So when we're talking primary brain problems, a lot of times that's a growth development too, that can affect that. And then problems with another body system. Our body is a big cog, and if we throw one of them off, it affects so many things too. Anyway, altered mental status is often rapidly correctable by treating the underlying cause, meaning hypoxia can cause altered mental status. We've talked about diabetes that can cause it. So if we can get them the oxygen, if we can get them the sugar, if we can get them those things, it's rapidly correctable by treating it too. Okay, so when we start assessing a patient with an altered mental status, what are your guys's, who have I got out here? We're going to start picking. All right, Kathy, Joe. I remember you have issues with your voice stuff too. So what would you say would be the biggest concern assessing a mental patient, an altered mental status? Can you hear me, Kathy, Joe? How about you, Omar? What would be the biggest concern that you would say for an altered mental status?
Probably somebody getting violent.
Perfect. Dead on, Omar. It really does come down to your guys' safety. When these guys, come back. When these guys get it, they don't necessarily know what's going on, and they can be violent, and they don't know their own strength. So you're dead on. They have can be dangerous to responders. Use law enforcement when necessary, and then be cautious, because because they start trying to act normal, or if they get quiet and seem to be at rest, a lot of the times it's the quiet before the storm is what you'll hear. And they, especially if they've been really fidgety, moving around, and all of a sudden they go really quiet, two things usually are happening. Either their condition is deteriorating really fast, or they're getting ready to have a violent outburst. 90% of the time, it's going to fall into those two categories. The other thing that happens with an altered mental status, as far as a danger to the patient themselves, is also an airway. When they lose the ability to control their mentation, they also a lot of the times lose the ability to protect their own airway. And that can either be breathing problems. A lot of times they'll salivate a lot, excuse me, and they won't be able, they don't consciously think, hey, we got to get rid of this, either by spitting or swallowing or whatever. So we got to watch for the airway problem with it. Be especially attentive during the primary assessment. And more of that comes back to your safety. And then you'll also find the keys to it a lot of the times. So like a diabetic, if they're low, a lot of the times they're shocky too. So their skin will be pale, they're going to be cold, they're going to be clammy. So as you're starting to see some of that, as you just do your hands-on with it too. And we've kind of hit too, carefully watch for indications of inadequate breathing. And then a lot of the times with these guys, they need some high concentration oxygen too. The only caveat I'll add to that with the high concentration oxygen, we used to say just throw it on them all the time. If we have the ability to get a pulse ox on them and get an oxygen saturation measurement, it's always better to do that. If they're in the 90s, then you can just bump them up with a nasal cannula. What? That's fine. Keep track of him. Okay. Love you. Thank you, buddy. Go and ask. Give me a hug and get out of here. Little butt. Sorry, guys. My kids just walked in. You're good. Love you guys. Bye. Be alert for indications of hypoperfusion. And the reason we say hypoperfusion, the other word that I like to throw in there is hyperperfusion and shock. Is their altered mental status, if they deteriorate, they'll be hypoperfused because they've lost that ability, and it's really the shock part of it that we're looking for. Determine the baseline for mental status for the patient. And this does need to be per the patient. There are some people that their mental status is not, they'll never hit the full mental status and the acuity that way. But we're going to do this by greeting the patient, assessing their ability to respond, and do a lot of the times on this until you guys get a good feel of what the patient's going to act like. I would have some distance, or at least any patient, I always say this, but with an altered mental status or a psych patient, you never want to allow the patient to get between you and the exit. Because if it changes, you just want to have a way to regress out of there. AVPU2 will help quickly categorize the patient's initial response. So are they alert to, or they have to have verbal or pain or unresponsive? Hold 1 second, just a second. Yes. They went to TJ's. Okay, just stop worrying about it for a while. That's fine. Baseline status can be difficult in children because, like, answering questions is differently than adults. So this goes back to, and this is where a lot of the times people in the written part of it, you need to understand that it's got to be, the question you can ask a 5-year-old is going to be different than the question you can ask a 15-year-old. So kind of be aware of, and it's easier too for if you've had kids or whatever around, because you'll understand, okay, is that normal for them or is it not? So it comes down to their age. And with the child, if they're not acting normal, who's the best person to ask if that's normal? How about you, Will? Who's the best person to ask if that's a normal mentation for a child?
Family member or caregiver.
Perfect. Yep. Family member, caregiver, parent, any of those. Somebody that has more of an intimate knowledge of that child. So altered mental status is a subtle sign that indicates a serious underlying cause. Is low blood sugar going to kill them right now? And the answer is yes. Okay. So a lot of the times, if we're having an altered mental status, the brain's not getting one of the three things that it talked about that it needed. It needs to have oxygen, glucose, and it needs to be hydrated. Okay. So if we're having an altered mental status, one of those three things is lacking, and we've got to figure out which one of those things it is. Okay. A body system exam and complete history may reveal important information about the suspected case, meaning we want that full history. What medications do you take? Have you taken them regularly? The word that a lot of the times you'll see in the test will be, are you compliant with your medications? Meaning, do you take them on schedule? Do you take them every day? All of those things, because a lot of the times, like antidepressants and stuff, we're seeing more of those in overdoses. Because people either don't take them or take too many of them, or take them one day and then don't take them for two, and it just throws them all over that way. We've already talked on the diabetes. Like the other altered mental status is narcotics, which we'll hit on in the last chapter today, but we'll talk about pinpoint pupils and things like that with them too. Interview family members, bystanders to obtain that patient's baseline mental status. If you don't have anybody there, let's say you find this guy in a wreck or just alongside the road, and he seems altered, a lot of the times we will assume that normally he mentates just fine. So you're going to have to make the assumption that he's altered for some reason and look for one of those three causes. We've talked about medications, other health-related items for relevant clues. Yeah. Oh, I'm going to throw one other one at you guys to consider, but we're going to go back to airway and relevant causes. So a lot of the times too, with the hypoxia, you got to look at anybody that has breathing problems or is on oxygen daily. What we find a lot of the times when we get called that they're having an altered mental status, what you find is a lot of these patients have 50-foot cord or 100-foot cord that they drag around with them through the house. And it's had a chair set on it, or they ran over it, or it's kinked. And so the machine's working, but they're not physically getting any oxygen. So some other clues for you guys too to look at that way. Be sure to accurately document the patient's level of consciousness over time. And then consider using Glasgow Coma scale to provide precise measurement of the patient's response. Diabetes, guys. For you guys that have heard me at the mine, I hit on these. The fun thing with diabetes is it changes the complete assessment. A diabetic doesn't present the same in a heart attack or any other way too. So it's a fun one. It messes with a lot of things, and we'll hit briefly on it tonight. So glucose is a form of sugar. It's the basic energy source, and it requires glucose to remain alive and create energy. If you guys really want to lose your mind, you can, we talked on anaerobic versus aerobic. Glucose, the body breaks it down if everything's working right into 32 ATP or 32 energy cells basically. But the body has to have that to remain alive. So sugar and carbohydrates are converted into glucose. Glucose is absorbed into the bloodstream. And the liver, believe it or not, is actually a huge storer of glucose for whatever reason, which when we talk about some glucagon stuff here shortly, we'll hit more on that too. So it's a large molecule and cannot pass through the cell without insulin. So remember, insulin, we talked, is the key. Without the key or insulin, we can have a ton of glucose in the bloodstream. If it's not getting into the cell without the insulin, it does us no good. Okay. When you see a diabetic patient that is extremely high, their blood, like when we do a blood draw on, it looks like syrup. It's so thick. And their cells, though they have all this glucose, but their cells are still starving for glucose because they don't have the insulin to let it from the bloodstream into the cell. So they're suffocating, for lack of a better word, on sugar and can't get it still. Okay. Insulin binds to that cell and allows it to pass through the molecule. And then normal glucose in the blood is essential to maintaining a mental status. You guys know, DJ, what's the normal, they call it decade. What's the normal range of glucose in the body? Anybody else want to jump in? You may be having some listening difficulties. So normal for the body is 80 to 120 or 60 to 120, depending on the book that you see. So there's a picture of it. The pancreas is where it is created, creates insulin, goes into the bloodstream, and then it enters, combines with the blood sugar to enter into the cell. So patients who are diabetic, most of, or well, I shouldn't say most, either do not produce insulin or they don't produce enough insulin. So usually the ones that don't produce insulin at all are type 1, and they are insulin dependent. Type 2, a lot of the times will take metformin, or there's a few other new ones out there now, but metformin still is a common prescribed insulin booster. Or they've become resistant to the insulin they produce. And that's usually a type 2 diabetic that doesn't manage it very well. Actually even becomes resistant to the insulin they produce, to the point they have to start taking insulin through an injection. The isolate of the Langhorne is the pancreas, produces the hormone insulin. Most cells outside the brain use insulin. That's what it's, like I said, it's the key to let it in. Once unlocked, the glucose can enter freely. Okay. When sugar intake and insulin production are balanced, you guys have a really efficient use of the glucose as an energy source. Does it very, very well. We've hit on some of this too. So diabetes mellitus results on the underproduction of insulin or the flat inability of the cells to use the insulin properly. So type 1, formerly known, like I said, is usually insulin dependent diabetic. They don't either they don't produce, or they're just not producing the function properly with insulin. So the synthetic insulin is used to supplement it. So the drugs that you guys will see, if they start, so it'll have a log. So like Humalog, Novolog, those are the two common ones that you guys will see. Those are an insulin. If you see that on the medication list, they're a type 1 diabetic. So type 2, formerly known as a non-insulin dependent, their cells fail to utilize insulin properly, or it's just not secreting enough. A lot of the times diet and the oral antibiotic, which is the metformin that we talked about, and sometimes if it gets really bad, they'll have a small vial that they can take some insulin, whether it's usually a Humalog if they do that. Hypoglycemia. Okay, so hypo is low glycemic sugar. You'll never see it on a test or in the book as low blood sugar. After this point, it'll always be hypoglycemic. It is caused by either too much insulin or too little sugar intake. A lot of the times what happens with these guys is they take their insulin just before a meal and then they don't eat. They get distracted, they get whatever, and all of a sudden their sugar drops to a low, way too low, or they don't eat as much as they thought they were going to and just don't get the sugar in that they needed to. Over exercising or exertion, right? It's the same thing. Your body's burning, either needs a lot of sugars. So if it needs a lot of sugar, what else does it need a lot of? Insulin. Okay, it's got to have the key to let it in. And then too, if they're not eating enough sugar when they're over exercising or over exertion, that drops they may have all the insulin they need, but there's just no sugar in the bloodstream. Vomiting's the same way. They get sick. And instead of having that glucose get into the body where it can be absorbed, they'll throw it back up and it never makes it into the body. The big part though is that last part, that last slide. If blood sugars reduce, brain and body cells starve. Okay. And that's what causes that altered mental status. So which one is more dangerous than, who else have I got on here? Kevin, which one is more dangerous, low or high blood sugar?
Low?
Low is perfect. So low will kill them right now. Low is usually a acute, and this is the other term you'll see with it in the test questions. Hypoglycemic is usually an acute event, meaning it's happened right now for something either fell off right now and so it happened, they go down now. Versus if it'll click through with me. So hypo, we've already hit on this. Its onset is rapid. The other one too, we've hit on this at the mind. It mimics a drunken stupor. So a lot of the times, like I said, cops have got tired of a diabetic dying in the back of their car because they thought they were drunk. So we get called a lot of the times to check blood sugars and stuff on the drunk, just to make sure they're really drunk and not in a hypoglycemic state. You'll see the tachycardia, rapid breathing, and seizures too. So for these guys, it is life or death. It's critical that we get the replenishment of blood sugar. Oral glucose is often used. What's the only caveat you guys can think of? Megan, why would we not give an oral glucose to somebody that's hypoglycemic?
Because it can make them really sick.
It can make them really sick. And the big one though that you have to have is a patent airway, and they have to be able to protect their own airway. So if they're downhill far enough, we've seen people try and stick a lollipop or Lifesaver or whatever in their cheek, trying to get it to raise. But if they can't protect their own airway, a lot of the times they'll end up breathing that into their lungs, if I can speak tonight, and then we get the pneumonia too. The RAS is what our RAS is, particular needs glucose, which is why you see that alteration in mental status. Any questions on hypoglycemic? Okay. And moving on to the chronic is the high blood sugar. It's caused by insulin deficiency, and then injections may be forgotten or insufficient. The other thing that messes with it is infection and stress and dietary intake. So if they've changed the way they eat, or they changed the brand of food or whatever, and all of a sudden miss that it has more carbohydrates or has more sugars in it than normal, it can start to send these through these levels high. It is usually a chronic though, takes days or weeks to develop. They have that chronic thirst, increased urination, nausea, and dehydration. Why do they have, let's put some of this together. Why would they have a chronic thirst, you guys think?
Well, if they're losing all that fluid, then they're just they're just really dehydrated, right?
Yep, they're really dehydrated that way, because if they're losing it that way, they're losing it faster, they can replenish it. The other part why they're doing it, so this is a term, if you guys ever take the advanced class, that you'll hear fairly often. The solution to pollution is dilution, meaning they have that thirst because they're trying to dilute their blood sugar. When you take a blood draw on it, it looks just like sugar. So they're trying to increase that urination to dilute it down, or make it to where their kidneys work harder to pee the sugar out. And that's why they have the increased urination. The body has two different ways to get rid of it. It can urinate it, or they can breathe it out. So it'll do both things. The deadly part of it is they slowly starve because glucose cannot enter the cells from the blood. So we have adequate sugars on board, it just can't make it into the body. Once it starts to burn fat, and when we start to have that, we get a lot of waste because it's not efficient, and can start to cause kidney failure and things that way too. DKA, diabetic ketoacidosis, is combined with the waste and dehydration. And some things that you guys will see with it is they do have a profound altered mental status, shock caused by dehydration. A lot of the times these guys, you'll need an advance to come on and start an IV, and they'll take 1 liter to 2 liters of fluid and do just fine, because their body's has been urinating so much to try and get rid of it. Rapid breathing, it's the same way. The body's trying to get rid of any sugar it can. I don't have this ability. If you have the right olfactory nerve, when you guys walk in, you'll smell an acetone odor on the breath. I don't like acetone. It's usually, when people that have it describe it, it's a sweet, flowery breath to it. And if you can smell it, you can walk into the room and be 50 feet away from these patients, walk in the door, those that I know that can do it, and go, wow, he's really high on sugar. Okay. So any questions on these guys? The one thing that I will say, it takes weeks or days to get the blood sugar to this level. Don't allow them or a bystander to hit themselves with a ton of insulin, because it can send them into an irreversible shock. It takes days or weeks to get to this point. It's going to take days or weeks to get them back to normal. Okay. Insurgent Safety, they may be agitated or violent, and they don't even know it. Okay. So just watch yourself with that. Perform your primary assessment, identify the altered mental status. And as we're doing that primary assessment, we're going to want to check for their breathing, both rate and quality. Move on to our secondary, try and get a history from the patient or bystanders. When you try and get a history on these guys too, a lot of the times, especially if they've had it and lived with it for 30, 40 years, they forget that diabetes is a medical history part until you get to the list of medications, because it's just something they've dealt with. It's no longer pertinent anymore. So determine how the episode occurred, the time and onset of the duration. A lot of the times with that, we're just wanting to see how long they've been down and how much potential brain damage we could be looking at. Identify associated symptoms and any mechanisms of injury and any interpretations to the episode, meaning did they have a trauma and now they have the altered mental status? Did we just eat? Did we take a medication? A lot of those things can play into it. Ask whether have been seizures or fever. It's the same thing. The fever or the infection a lot of the times isn't what causes the problem. It's the fever that we got to look at. So sample history for these guys. We want to determine if there's a history of diabetes, right? Look for a medical ID bracelet or wallet. A lot of them, and now too, have that implanted insulin pump. It looks like a pager or something on their belt. So look for that. It would be a good one. Note any oral medications. Like I said, metformin is the big one. And then the new Novolog and all that. It's not an oral medication, but it's one to watch for. And also too, a lot of the times a diabetic, when you go into their kitchen or their living room or whatever, if they're monitoring it right, they'll have a journal and a glucometer. So either in their kitchen, in their living room, whatever, that they're checking and recording this. If they have that, take a look at their what their normal usually runs at, because if they're normally at 200 and we take this blood glucose monitoring, which I don't know of any local protocols that don't allow you to do that, and all of a sudden they're at 150, but they're usually at 260, are they low? And they are, because they're not used to that. So, but are they above the normal rate still? Yeah. So you got to ask on these, you got to get their normal, because it really can, it's patient dependent. Okay. So we always determine that. I like on that too. When we start talking about that, we're going to treat the patient, not the vitals. Get his vitals and see what we've got. If he's low, we're going to determine if the patient is alert enough to swallow, or the other term that you'll see on the test questions is can he protect his airway? Okay. Take our baseline set of vitals. Observe for sight. That should be signs. I'll have to go back and fix that. Observe for signs and symptoms of a diabetic emergency. Was it a rapid onset? Did they have the intoxicated appearance, cold, clammy skin we've already hit on, elevated heart rate, and extreme hunger? And the other two with the thirst, a lot of the times they have a thirst for sugary drinks like apple juices or pops or whatever. That's what they want. They usually don't want water per se. Observe for the other part of it, uncharacteristic behaviors, anxiety behavior, combativeness, and seizures. I feel like we beat those all to death already. It's important to determine both the hypoglycemic and the ability to swallow to administer effective field treatment. So a glucometer or a glucose meter, if possible, makes it possible for the patients to test their glucose, and it also helps us. Testing helps patients know how much insulin to take and when and how much to eat, and it reduces diabetic-related complications. Continuous glucose meters can test as often as every 5 minutes via sensor under the skin. That's a new one that's come out, but they have that ability. And if at all possible, don't use that patient's glucometer. You would be shocked at how often these things are supposed to be, especially the older ones, need to be calibrated and checked. And a lot of times we'll come on scene and they said, well, I checked my blood sugar and it was fine, and we'll do it with our meter. And it's like, no, it's not. It's just a matter of the fact that their home glucometer is not working. So this is usually what it'll look like. There's three things that are with every glucometer. You get an alcohol strip, which is in the middle pouch. Those little orange things to the right are the lancets. and then the test strips are right below the meter itself. We'll walk you through, that's part of the skill sets that you guys have to do when we start hands-on. But that's what it looks like. Anyway, we'll hit more on that when we do the hands-on. So for this one, we'll say they're saying less than 60 causes some symptomatic, less than 50 causes significant alterations, and then greater than 140 and greater than 300 can cause some of that too. It really comes down to the patient, though, guys. I hate throwing out these. I mean, these are normal. This is what they're going to use for test question stuff, but it comes down to what's normal for the patient. I've had multiple ones that when we did a blood draw in the ambulance, it said high, which most of our meters top out at 600. I've had 5 of them that were over 1200, and we're completely out of it.
Well, you wouldn't know that at the top side.
Yeah, it just says high. And the only way we knew that is once they got to the ER, did a blood draw on them there. Okay. And then I've had ones that were cleared down around 45 and talking to me and just fine. But I've also had them in the 120s, 140 range that were unconscious because they're usually at the 250 to 260 range. So it really does come down to the patient. Always question, and that's what this one's talking about. If it's inconsistent with what your guys are seeing, they can be expired, had too little or too much blood. That's the belief. And then the meter may not have been used or properly maintained. And then it could be out of calibration. So this one's saying, and the same thing, it comes down to your meter. A lot of them now, their high level is at 600. The older ones are at 500. Low is below 15. Most of the time with the diabetic, if they're low enough that it says low, you're going to see it before the glucometer ever will tell you that. Occasionally mild hypoglycemic and minor altered mental status can be treated by eating and drinking. Same thing though, guys, they have to be able to protect their own airway and waken up to swallow. Okay. If the patient meets a criteria, let them squeeze a tube of glucose. So ambulances, we carry it in a little tube. If you would think it would taste great, it is nasty, thick, yucky stuff. So if you're going to give it to them, just warn them of that because it can make them throw up too. And then the other one too that I'll throw on this one, if you're seeing an altered mental status and we're suspecting that there could be something, but the glucometer's showing us a 160 and they're still altered and are able to swallow glucose, you can still try and give it to them because is low or high going to kill them? We've already hit that lowest. So if we give them a little more and we bump them from 120 to 300 and it doesn't change their mental status, oh well, it's really not the end of the world. Okay. And if they were already at 1200 and we gave them 200 more, difference between 12 and 14 in the long run isn't going to make the damage is already done. Reassess the patient after. If there's no improvement, consult medical direction. If they're unable to swallow, we're going to secure the airway, provide artificial ventilations. And then the other one that I'll put the slash on that is suctioning as well. A lot of the times with an altered mental status, for whatever reason, when you lose that ability to mentate, you lose the ability to protect your own airway. If ventilations are not required, we're going to place the patient in the recovery position and request ALS because we can do glucose via IV. We've hit on that one. I beat that one to death. Their ability to swallow. Yeah, only if they can protect their own airway. So our OPQRST questions, the three that are really important to it is the onset. And we've hit on this one too, right? Hypoglycemic, so high has a slow onset. Hypo tends to have the suddenly, so it's chronic versus acute. Hyper, their skin is usually warm, red, and dry. Where hypo, it's cold and clammy. It's shocky, is what you'll see with them. And then hyper with their breath, if you have the olfactory nerve that does that, you'll have that acetone or sweet breath smell. Hypo, it doesn't have any specific one to it. Patients with the hyper breathe deeply, intensely thirsty, and have abdominal pain or vomiting. Their body is literally trying to get rid of sugar any way it can, whether it's breathing, urinating, or vomiting. The other one that they don't put on here a lot of the times is diarrhea too. Body's just trying to get rid of it in any way it can. It's not necessary to distinguish between the two conditions to give proper field treatment. And that goes back to we're going to err on the side of caution. If they're diabetic with an altered mental status, we're going to err on the side of caution and give them a little glucose. Because it's not going to harm them. So we'll talk now seizures and some seizure disorders. So if the brain function is upset by injury, infection, or disease, the brain's electrical activity becomes irregular. And it can bring on sudden changes in sensation, behavior, that way too. Partial seizure, I want to hit on this a little more and teach. I want to talk to you on this one a little differently. So we talk about when we have a heart attack, and we go into VTAC or VFib, it's when the electrical activity in the heart is not controlled, it's not doing what it does. It's the same thing in the brain. The neurons in the brain are firing erratically, uncontrolled, and way too fast. And that causes a spasm that way too. I just like that. For me, it makes more sense if we can tie it together. It's the same thing happening in the heart as it is in the brain. But when it happens in the heart, we call it a heart attack or VTAC, VFib. In the brain, it's a seizure. Partial seizure affects only one part of the brain. Again, a lot of the times you'll see the convulsions in the patient with a fully mental status, meaning their arm or whatever. They'll lose control of it and it'll just do weird, funky things. Erratic movements is a lot of the times what they'll term it to. And then some patients may briefly lose consciousness without convulsions. Most of the time, when we picture a seizure, we picture somebody laying on the floor, the tonic, clonic, the full body thriving, uncontrolled, whatever. 3/4 of the seizures have no erratic body movement with them. You'll look at them and they literally can be talking to you, lights go off, 30, 40 seconds later, lights come back on and they're right back into mid-sentence. They have no idea. The only reason they know they had something is they look at your eyes and your eyes go a little bigger, like what the heck just happened, okay? Or they'll be sitting there and they'll just go freeze, okay? So I just hate to teach you guys and have you guys think that it has to be a full-on body seizures. Most of them are not. Most of them don't have a full tonic clonic. So generalized seizures affect the brain and affect the consciousness of a person. Most of the time though, because people don't recognize that we are called for the tonic clonic seizures, because that's the one that it often characterized by unconsciousness and major motor activity. These guys, it says a lot of the times that it has no warning. I would dare bet the ones that I've went on, about 50% of them, they call it an aura. So they'll get a feeling, or they know a seizure's coming, and they'll try and take steps to protect themselves. So if they're standing, they'll lay down on the floor, do whatever they need to, so when it comes, they don't fall right to the floor. Because that thrashing wildly, a lot of the times, that's what causes the damage. Is not the seizure itself, it's the severe movement thrashing around of the body. So the tonic clonic seizure has three phases. So the tonic phase, the body's rigid for up to 30 seconds. The scary part is what people watch, they may stop breathing for that 30 seconds or longer. Bowel and bladder control may be lost. The clonic phase, the body jerks violently for 1 to 2 minutes. They may foam at the mouth, face and lips may become cyanotic. If their muscles are uncontrolled, their diaphragm and their intercostal muscles are not doing what they're supposed to, so they lose the ability to breathe a lot of the times for that 1 to 2 minutes. And funny enough, a lot of the times when the brain gets so cyanotic or hypoxic, that's what stops the seizure. Because it no longer, those neurons can't fire because they don't have what they need to fire, and that's actually what stops the seizure. So let's say though too, we are dealing with a 15-year-old that just had a seizure, lost bowel and bladder control in the middle of the school. What's some thoughts you guys have there? What's another major concern we have as we start dealing with that? Yep, right on. Their privacy and the people, their peers that are around them. And even an older adult can have some, if they're in the workplace and have that, it can be embarrassing. But if we're dealing with that in public, be mindful of that. They can't control it. And it's embarrassing to them, and just be mindful of what they're going through too. And then the third phase of it, which most of the time this is when we get there. You look at the time frame on that, they're rigid for 30 seconds, they jerk for 1 to 2 minutes, and then they go into this post-ictal, so 4 to 5 minutes. Most of us, from the time of the page to on scene, is 12 to 17 minutes. So when we get there, hopefully they're in the post-ictal stage. That convulsions stop, regain consciousness. They may be drowsy or violent there, but it's the same thing. Though their brain is hypoxic. They just stop breathing for up to 3 to 4 minutes. They're severely hypoxic. A lot of the times, just give them a minute and they'll come around. Why was it that they would be drowsy or tired? How much sugar do you think these guys just burned? A lot. Yeah, every one of their muscles just flexed and uncontrollably violent for 2 to 3 minutes. It drains these guys bad. So they're drowsy. They just need time for everything to reset. We've already hit on the sensation, smell, or the general feeling. It's called the aura that comes before it. The most common causes of seizures in adults is failure to take prescribed anti-seizure medication. The sad part is a lot of the times when we get called, is it the adult or the teenager that we're trying to figure this out? It's usually the teenager that they don't know. For these guys too, for us at the mine, we don't have this, but if you don't have an ALS crew, the advanced and the paramedics, we have medications that can stop seizures, especially. So if it went 5 minutes, are we necessarily going to cause irreversible brain damage from hypoxia in 5 minutes? Most of the time, no. They can go 7 to 8 minutes. If they hold that seizure and stop breathing for 12 to 15 minutes, now we're in trouble because the brain can't go that long. And it's already hypoxic, and that reset, for whatever reason, didn't work. We have midazolam or Versed, and we can give that one, and it will knock out that seizure. It'll knock out all muscle activity. In children, no, most of the time, 90% of the time, unless it's, if it's not they call it a febrile seizure, so it's a fever seizure in a child. Most of the time, that's what you'll deal with in a child. For all you moms out there, if you have a sick baby, what is a thing that most of us try and do with them?
Coma.
No, we wrap them in blanket after blanket after blanket after blanket after blanket. And so they'll bump their fever, and a lot of the times all these little kiddos need is unwrap them, take their onesie off. Yeah, you just want to be careful with the like a cool tub or a rag, because you can send them into shock the other way by dropping it too fast. Anyway,
Does that medication make it so that they lose their airway, that they lose the ability to keep and maintain their own airway when you give them that medicine? Do you have to watch for that?
if we do that, yes, that is a huge concern with it. You're dead on. Because it does knock out. So if you guys are on scene and we give that as an ALS crew, yes, because it stops all muscle activity. It's actually a sedative. So once you give that, airway management is huge after that. So if you guys are running with an advanced crew and we give it, yeah, airways are a big concern after that. You were dead on, dead on. Other causes of seizure: hypoxia, stroke, or traumatic brain injury. Toxins can do it too if we get too low. Brain tumor. It's sad to say, but often the first sign of a brain tumor is a seizure. And we had that at the mine, actually. Congenital brain defects. That's usually in children. If you're seeing an adult, a lot of the times they're on medication and things, and they ask them how they deal with it, because they know what they need to do. And a lot of the times it's not the patient, it's more of the caregiver or parent or whoever's around. Infection, metabolic or idiopathic. Idiopathic ones are, we don't know why it causes that, and there's some ways to test for it. So if a person is having a true seizure, if you lift their head and they're laying down, if you lift their arm above their head and drop it, if they're in a true seizure, they'll let their hand smack their head. If they're not, as it hits just before it gets their head, they pull it away. So if they pull it away, it's usually an idiopathic seizure. And we just, for as much as we know about the human brain, we truly don't know what causes that. I mean, they just happen. Epilepsy, measles, mumps, and other childhood diseases. Eclampsia. So eclampsia is in a pregnant woman when it's down over the cervix instead of, on the sidewall. So it passes first. Usually has to be cesarean. When they get further into it, they can have eclamptic stroke, heat stroke, and other onset of syncope. So this onset of a syncope, meaning you get some stupid high school kid. It used to be a lot more popular than it is now, or at least we don't see it as often, but they'll choke themselves out and cause a hypoxic event. And then once they choke them out, they have a seizure because of that. Okay. Or a car wreck or anything that made it to where they couldn't breathe, and all of a sudden you relieve that and they can breathe. Sometimes they can go down into a seizure. Most of the time when you see it, it's stupid teenage boys that choke somebody out. Epilepsy is an umbrella term. It's kind of like when we say they had a heart attack. Well, was it an anterior lateral? Was it a septal? Was it medial? We just say a heart attack. So epilepsy is the same thing. May be present from birth. Hello. Oh, thank you. Oh, thank you. I will correct that. Thanks, Lonnie. Okay, thank you. No, you're good. Thank you. All right, so Bonnie just got back with me on that. So eclampsia, I led you wrong, is high blood pressure in pregnancy. So you're just watching for high blood pressure. May be present from birth or develop later due to injury or surgery. Medications, though, usually allow these people to live a normal life without seizures. It's important as you guys get information from the people that witnessed it and describe it to the emergency department personnel, meaning what was the person doing before the seizure started? Was there an aura? What exactly did the person do during the seizure? Loss of bladder? How long did it last? That's a big one because we're looking at how long they were potentially without oxygen. And then what did the person do after the seizure? Meaning, did they go flaccid and just wanted to sleep? Or did they ever regain consciousness to where they could talk to you? Or did they just go into the unconscious part of it? Anyway, just pass that on to the ER so they can treat from there. A patient seizing on arrival is a priority transport, and a lot of that times it goes back to the time frame. If they're still seizing when we get there, they've been seizing for a long time, and they've been potentially without oxygen for quite some time. The big part with it, though, is we're going to protect the patient, right? We're going to place the patient on the floor or ground, lose restrictive clothing, remove objects that may harm the patient. Do not try and hold the patient during convulsions. If there's a vagal nerve stimulus, it's a magnet. Allow the family member to apply it. The thing I'll tell you too with the don't hold them down, the thing you do have to watch, if they start thrashing and it's a hard surface and they're smashing their head against a hard surface, they could cause problems that way. So sometimes you'll have to cut underneath their head and let them smash on your hands. Try and hold their head just above the ground so that your hands act as a shock absorber instead of a concrete or hard floor. Because they can and will hit their head hard enough that they can cause head injuries too. So if they're actively seizing, though, how are we going to strap these patients down? The answer is a lot of times you won't be able to. If they're thrashing wildly enough that you can't strap them on a board or the gurney and try and hold them on. It's the same thing. If they're pulling hard enough and you try and lay on them, they'll literally break their bones. They can cause issues that way too, because it's such a strong, uncontrolled muscle reaction. So most of the time with these patients, if they're actively seizing, we've got to get the seizure stopped before we can transport for their safety and for yours too. Yeah. After though, once they hit that postictal stage, we got to protect the airway. If they're cyanotic, open the airway, suction it out, provide artificial ventilation or oxygen treatment, and then treat any injuries that may have been sustained during the convulsions and transport to a medical facility. Never place anything in the mouth of a seizing patient, including your finger, if you want to keep it at least. Same thing when they have the seizure, they'll squeeze down. If they have a hard enough muscle contraction to break their own bone, I promise you they'll break your finger right freaking off. Okay.
You don't want to have them bite down and break an object and obscure their own airway
so
as well.
And Liz has a great point that way. If you stick something in, they bite hard enough and chew it and then suck it in and aspirate it.
You can't get into their mouth to fix it. You can't get it out. They're seizing.
The other reason we'll get called to is if they've had 2 or more convulsive seizures in a row or a single seizure that lasts more than 10 minutes. Is a static epilepsis. So they're static, meaning that it's either lasted for 10 or within 10 minutes, there wasn't a 10-minute break in between the two seizures. So from the time they stopped seizing from the first one to the time they started seizing from the second one, if it's less than 10 minutes, then they're a status. Or if the initial one lasted more than 10 minutes. This is a high priority transport requiring immediate transport, and ALS intercept. Just take that may also, it's going to be necessary. An ALS intercept is going to be necessary.
With that one that we had up there at work, when he came out, he thought he was totally fine, everything was all good, and that he was good to continue to work. And then I had to actually push to make sure that he actually went and was actually seen by medical. Should they always be that way? Or?
A lot of the times they, especially if it's a new one, they don't want to admit it because there's another, a lot of the times it's more fear than anything, because the fear that there's more to it. So yeah, they fear the unknown. By all means though, if they've had a seizure, that is just, to me, that no questions asked. They come out from the mine and they go home, preferably to be seen by medical. If not, just get out from away from that big equipment. I mean, can you imagine somebody walking down the entry, having a seizure and having the shuttle car come down the entry? And that thing weighs what, over 50,000 pounds loaded? If it went over the top of them, they'd be dead. Or even scarier, they're driving that 50,000 pound machine and have one and run over somebody or into something, or anyway, just it's too hazardous to have them that way. But yes, oftentimes they don't want to go, but it's not, they don't remember it, they didn't see it. A lot of the times they think you're making it something that it's not, and then they just don't. Ignorance is bliss too, anyway. The simple partial seizures involve tingling, stiffening, or jerking of one part of the body. A lot of the times with these, they have that aura. There's no loss of consciousness. In some cases, the jerking may spread and develop into tonic, clonic seizures. A lot of the times with these, if they're having these simple partial ones, keep them in a quiet area, not a lot of bright lights, not a lot of sudden movements. Anything that stimulates the brain, whether it's lights, pungents, perfumes, sounds, lights, anything that can stimulate it, we're going to want to keep away from these guys, because we don't want to stimulate that brain. We don't want to stimulate an already overstimulated brain. So the complex partial seizures is characterized by an abnormal behavior that varies widely. So, and these are what, I know you can't confirm this over the whatever, Bonnie, but I mean, correct me if I'm wrong on a phone call. Most of our seizures are this. They have that confusion, that glassy stare, lip smacking, fidgeting. They appear to be drunk or on drugs. They can be violent or may struggle if restrained. And I hate when they say, if they're violent, they will struggle if they're restrained. Just take the frickin' may out. If they're violent, they're gonna struggle to be restrained. If they're not, too, they may struggle to be restrained too. Meaning the way they're saying that one is, if they're hypoxic, they're either low on sugar or low on blood, and they have no idea what they're doing, but they feel it's the fight or flight, life or death type deal, and they're going to fight for that. But there is no loss of consciousness. But the other one that goes back to your comment earlier is there is no memory of the episode. They have no idea. No idea it happened. A lot of the times the only reason they know it happened is the people's reaction around them. The other one of it too is generalized seizures. There's two types. So the peak mal seizure or the absence seizure, brief, 10 seconds, temporary loss of consciousness or awareness. And for these guys, it may occur hundreds of times today. Does not involve motor activity though. This is the blank stare, lights are on, lights are off, lights are on, lights are off. Versus the tonic clonic seizure, it involves the entire body, and that's the ones you'll get those convulsions, erratic, uncontrollable ones that way. Patients with epilepsy tend to be knowledgeable about their condition. Seizures may be common. They may refuse transport, but we have to make sure those that refuse transport are not left alone and do not drive. And that's where I go for you guys, for us at the mine. They can't be left alone. By all means, get the damn controls of any equipment away from their hands, and don't let them drive a UV or truck or anything like that. The only reason we say that is a lot of the times if they have one, there's a high likelihood that they can have another one until whatever caused said seizure is corrected, whether it's medication, overstimulus, like brain sound, sounds, whatever. Until we correct that, there's a high likelihood that they can go back into it. We just don't want to have them in any situation where they can hurt others or themselves. Stroke is the death of or injury. Okay, we're going to take, before we dive into strokes, let's take 10 minutes, guys, and we'll jump back in at 7:30. Just because my voice is gone. All righty, guys, here we go again. So strokes is the other cause of altered mental status for us. When we start talking on these, there are two different types that we definitely need to talk about with it. So stroke is the death or injury of the brain tissue from oxygen deprivation. Ischemic stroke is normally what we see. An ischemic stroke is caused by a blockage due to a clot or an embolus obstructing an artery. So do you guys know what the difference between a heart attack, a pulmonary embolism, and an ischemic stroke is? Where the clot lands. So if it lands in the heart, it's a heart attack. If it lands in the lung, it's a pulmonary embolism. And if it lands in the brain, it's an ischemic stroke. The big one, though, that we want to know the difference on is hemorrhagic stroke. It's caused from bleeding or a ruptured blood vessel in the brain. It's often the result of a long-standing high blood pressure, can occur with the weak area of the artery, bulges, and eventually ruptures. Or the other one that I'll add on to it is trauma. If they get hit in the head hard enough that they have one of those weakened arteries and it can tear them. So different patients exhibit different signs depending on the size and location of the arteries involved. So one-sided weakness is usual. Side note to it is it usually, so if we're seeing left-sided weakness, is it the left or the right side of the brain that's being involved? It's the right. Okay. They have a difficulty speaking or a complete inability to speak. Headache caused from bleeding of the ruptured vessel. If they complain of a severe sudden onset headache, 95% of the time, if that is immediately prior to or the first sign they have of that stroke, it's usually a bleeding, hemorrhagic instead of an ischemic. Deviation of the eyes, inability to recognize parts of the patient's own body. And then the other part of it is they have, it's the next slide. One-sided weakness, if it's a slow onset without the headache, most of those are usually a ischemic, meaning a clot. If we have that severe headache, it's usually a hemorrhagic. When these guys communicating with them can be difficult because of the damage to the brain affects word use. This frustrating part with the patient is they know what they're wanting to say. They know what they want their body to do, but they can't because of the stroke. They just can't get it. They can't get the body to move where they want. They can't get it to say what they want, and it gets very frustrating, and they get agitated with that. So the aphasia is a term generally for difficulty communicating. Inexpressive aphasia is the patient knows what they want to say, but they use the wrong words. Receptive aphasia, the patient cannot understand, use, so responds in ways that don't make sense. And that goes to their brain because of the damage, is misinterpreting what you're saying because of the damage to it. A transischemic attack, a TIA, is the patient exhibits stroke signs that resolve within 24 hours without medication. Small clots, temporary block circulation to the part of the brain causes stroke-like symptoms. What happens though is the symptoms resolve when the clot breaks up. So the body's natural clotting factors take over, break the clot down, the damage goes away. Period of hypoxia is short and there's no permanent damage. But the patient is at risk for full-blown stroke and should be evaluated as soon as possible. Once they start throwing a clot, that's highly likely that they're going to throw another one and another one, and they tend to get bigger and bigger. So they want to be evaluated and look at clot busting drugs or blood thinners or some of those things to go with it. So using the Cincinnati stroke scale is the one that we use in EMS. First part we're going to do is ask the patient to grimace or smile. And we want to see if the response is unequal or no movement, or if it is equal. Okay. So ask them to smile. Ask the patient to close their eyes and extend their arms straight forward for 10 seconds. And you're going to look for drifts. So meaning if one arm starts to go up while the other one stays, or if one arm starts to go down while the other one stays in position. So we're just looking to see if those arms drift or not. Or if the arm goes from palm, so we say, close your eyes, extend your arms straight forward. We usually have them do palms up like the picture shows here. And we're looking for if that arm drifts or in the other. So if it drifts, there's a picture of drift, and then the hand usually rotates down. Then the other part of it, we're going to use the ask the patient to say, you can't teach an old dog new tricks. Anything with S's. So somebody that is having a stroke, S's, they have a really hard time saying. The other one that they say is it's always sunny in Cincinnati. Anything that requires S's require a fine-tune in your the fine-tuned muscles in your tongue to say it. And if you're having a stroke, you've lost those control. Some other signs with it, they can fluctuate in severity depending on signs and symptoms, and can fluctuate in severity. So if it's a smaller clot and a smaller vessel, you're not going to have as many of these. If it's a larger clot in a larger vessel, it obviously affects larger amounts of the brain. So some confusion, same thing. They don't understand. They know something's wrong. They just don't know what it is. So they get confused. Dizziness, the same thing. They've lost the fine-tuned muscles and control of them. So they get dizzy. You have the numbness, weakness, and paralysis, often one-sided. Same thing, loss of bowel and bladder control, impaired vision, high blood pressure, difficult respirations or snoring. And the reason with the respirations and snoring, it's the same thing. They've lost the muscle control, so everything relaxes and they'll snore. Their tongue will relax, their neck muscles will relax, and they can snore too. And with the snoring too and difficult respirations, a lot of the time you need to suction these guys. They'll have a lot of secretions in their mouth. They'll have the nausea or vomiting, can't have the seizures, unequal pupils, headache, loss of vision in one eye, and unconsciousness is uncommon though. Usually if somebody says they had a severe sudden headache, and 5 or 10 minutes later they become unconscious, that means it was a large blood vessel that ruptured, and we're creating some serious increased brain pressure, and that's why they went unconscious. Those are fairly uncommon. Recognition is the most important step in the stroke care. Many conditions mimic a stroke, but it's always better to overtreat a suspected stroke than undertreat. It's time sensitive, and the longer the vessels are blocked, the more damage will occur. So when it's time sensitive, we have to note when the last time is that they were seen normal. The sad part with that is so let's say mom, dad, grandma, and grandpa goes to sleep at 11 o'clock at night, 9 o'clock at night, whatever, wake up at 6 o'clock in the morning, and now they're showing signs of a stroke. When was the last time they were seen normal? 9 o'clock that night. So a lot of the times we have to assume they went to sleep, immediately had the stroke, and that's why they slept. Okay. But we need to note the time. The most important treatment is often rapid transport to appropriate destination. For a conscious patient, you can maintain their airway, calm reassurance, monitor their airway, administer high concentration oxygen, and then transport the patient. For an unconscious, though, we're going to have to maintain their airway, suctioning OPAs if we can get them in, and we're going to use a BVM and ventilate for these guys. Transport to the hospital with the capabilities to manage a stroke patient per local protocol. The thing I'm going to tell you for both sides, whether you're Carbon County or Sanville County, Castleview and Sanpete Valley are a stroke receiving facility. They're not going to stay there, but they can do the clot busting drug. We can do the imaging. We can do all of that at both of those facilities. So that's going to be your appropriate facility. Use of some treatments is time sensitive, meaning we have these clot busting drugs. Bonnie, I'm going to ask you this question because you see it more than I do. I thought it was 8 hours. Have they lowered it to 3 hours now? If you don't mind just texting me that one, or Doug, if you can ask her, because I thought it was 8.
She
What's
left.
that?
She left. I'll ask her when she gets back, though.
All right, thanks, Doug. CT shows no evidence of a hemorrhagic stroke, and then blood pressure is not excessively hypertensive. And then be sure to document the exact time of the symptom onset. For now, I guess we'll go with the 3 hours, but usually most physicians at 6 to 8. So I'll have to get some clarification on that one for you guys. The big one though too, document, transport. This is not a stay and play patient at all. Most of our treatment and stuff is going to be done in the ambulance on the way to a stroke receiving facility. Dizziness and syncope, same thing, may indicate a serious life-threatening problem. You may be unable to diagnose it other than a cause of mental status, but you can treat life threats and gather information. So if they have weakness, vertigo, lightheadedness, excuse me. The big thing with them is their protection. So if they're weakness and vertigo, we're going to transport these guys, easy movements. We're not going to do anything that makes them have to exert a lot of energy. So if we can get them on the gurney and take them out. Same thing with these guys too. If they have that weakness and vertigo, a lot of the times shut your lights off, shut your sirens off. We don't want to cause anything that makes it worse. And speed and stuff is another thing that also oftentimes affects vertigo. So syncope, when we start talking about it, it's a brief loss of consciousness with a spontaneous recovery. Meaning most of the books put it in the term loss of consciousness for 30 to 90 seconds. So it's fairly short. And the spontaneous recovery means that nobody had to do anything with them to wake up and say, oh, hey, what just happened? Okay. They often have some warning that the syncopal episode may occur. They get that, this room starts to spin, they get that bright going that way and can cause issues that way. Hey, Bonnie. Uh-huh. Okay. So it is 3 hours now. It used to be 6, I thought, but maybe I'm thinking of a different one. Okay, perfect. Thank you. Okay. So on the TXA, which is the drug they usually give for it, they are saying 3 hours now from the last normal. There's other criteria to get them out and other medications, but TXA is within 3 hours of onset. So for us at the mine, that can be a little bit of a scary deal, right? They have a stroke and we're down in the bleeder, you're 45 minutes out, you're 45 minutes to the hospital. So you're already an hour and a half, we're well into that 3 hour window. So it really is become time sensitive. Anyway, any questions on stroke before I jump back into syncope? Okay. May experience some dizziness, vision, changes in sweating. In some cases, bladder or bowel incontinence may occur. So that just means incontinence, they lose control of it. So they may urinate or defecate too. Oftentimes, though, it is a cardiovascular cause, meaning that they have a Brady or tachycardic episode. So their heart either got going too slow or too fast, and now we're not moving blood fast enough to the brain. They have a syncope episode. The reason why you have that is we're trying to get the brain down to the lower to the heart. So when you pass out, you fall down, blood starts going to your brain easier, and we can start to stimulate and get oxygen and sugars to the brain. Acute myocardial infarction, heart attack, abnormal heart anatomy, sense of carotid sinuses, especially in children. And then they call this last one stimulation of the vagus nerve or vasovagal syncope. Guess where we pick up most of those? It's usually an elderly patient that's constipated, and when you bear down really hard, you can get a vasovagal syncope. So they pass out and then fall between the toilet and the wall. I'm going to find the architect that decided to put the toilet in that little stupid cubby behind the shower in most houses, and I'm going to kick the crap out of him every day in heaven because I hate picking patients up there.
Or without attitude, you may not make it there.
I may not make it to heaven to kick him. That's okay. I'll still find a way to kick him. Hypovolemic causes can have a low blood volume or low fluid, usually dehydration, internal bleeding, or trauma. This is the ones you see like a trauma patient or dehydrated. If they try and stand up and move, they'll pass back out. It's the same thing. There's not enough blood for the heart to pump efficiently to the brain when you're standing. So keep these guys setting, get them something to drink. If it's internal bleeding, we've got to transport them. If it's a trauma, we got to treat any bleeding we can outside. Metabolic or structural causes, so you can have inner or middle ear problems. These ones for the patients are, so in your ear, you have little hairs. And what happens on it is a lot of the times they get crystals on them. So when you set up, your eyes are telling your brain that you're setting up, but your ears are telling your brain you're laying down, and they don't jive. So the patient gets confused and they have a syncope episode and they go back down. And then every time you try and set these guys up, they have the same thing. It's the weirdest thing. Hypoglycemic, we've already hit on it. Strokes and seizures as well. The fun ones, alcohol and other drugs or depressants can cause it too. Carbon monoxide poisoning, panic and anxiety attacks. And then other causes in half the cases too, no cause is ever found. So for whatever reason, their body just, something wasn't firing right. By the time we run all the tests, it's corrected itself and nothing is ever found of it. So rapidly identify and treat our patient assessment and treat flight threats, ABCs, right? Airway, breathing, circulation. Gather important information. Describe what you mean by dizziness. Was the lights? Was the room spinning? Did you get shaky? What did dizziness mean to you? Because dizziness, it's a very vague term, and just ask them to describe it to you. Did you have any warning? If so, what was it? That's the aura we're looking for. When did it start? How long did it last? What position were you in? And then oftentimes, this is not the first time. So have you had any similar episodes? And if they have, what's the next question we want to ask? What did they do last time to treat it? Okay. Last time, if they had to run them up to the the cath lab or whatever to treat it or readjust pacemakers or whatever it is, there's a really good chance we're doing the same thing. Are you on any medications for this problem? Syncope or, so I mean, that one's really vague too. So what kind of problems could cause it? You know, do you take any medications for high blood pressure or your heart rate? Do you have seizures? Do you have, are you a diabetic? I mean, there's lots of different ones that way that can cause them. Do you have any other signs or symptoms? Did you witness any unpleasant sight or experience or strong emotion? That's just going back to did it stimulate something that normally doesn't? Did you hurt yourself? I don't like that question. For me, it's, do you hurt anywhere? Especially if they just had a seizure. You know, do you hurt anywhere? Did you hit something? Did you cut yourself? Whatever it is. And then, did anybody witness involuntary movements of the extremities like seizures? The greatest danger for a patient with syncopal is falling. Ensure the patient is in a safe environment. Help the patient into a safe position on the floor. Provide aftercare. Lay the patient flat, loosen tight clothing around the neck. Administer oxygen. Call for ALS. And treat any injuries the patient may occur. Okay. Any questions on that one? Take 5 minutes. Give me just a second. We'll get the next slideshow up. I got a question for you, Liz. So I figured out, like, I can move over to here now. I'm trying to see though, is there any way to move this set of controls? Oh, there it goes. All right, guys, we may just go ahead and keep moving. You guys out in Zoom land, are you seeing chapter 23, allergic reaction?
Yeah, I can see it.
Perfect. Here we go. So some topics we'll go over. We'll talk about allergic reactions, self-administered epi, and then ENT administered epi. So an allergic reaction is the immune system's natural response to foreign body or substance in order to get rid of them. When we talk about allergic reactions, though, an allergic reaction is an exacerbated immune response, meaning it's overreacting to it. An allergen, so two things we have to have with it. We have to have an allergen, which is the substance that causes it, and then we have to have that immune response. Okay. When we talk about anaphylaxis or anaphylactic shock, it's a severe life-threatening allergic reaction. Geez. What happens with it? Blood vessels dilate rapidly, causing a drop in blood pressure. So you have hypotension. So we've taken a 5-gallon bucket, we've made it into a 10-gallon bucket, not enough blood to fill it, so we get low blood pressure. Cells leak fluid into the interstitial space, tissue swell. Where it becomes an issue for us is the airway also swells for whatever reason. Common causes of allergic reaction, you can have insects, so bees, yellow jacket wasps, hornets, foods, nuts, eggs, milk, shellfish, plants, medications. The most common one is penicillin, dust, chemicals, and other soaps. And then also, like with insects, a lot of the people have cat allergies, dog allergies, whatever it may be. Okay. Latex allergy is a particular concern with EMS. Because of that, most of our stuff now is latex free, our gloves, all of that, just so that because it's, for whatever reason, it's become fairly common for people to have a latex allergy. Patients who have had multiple surgeries are increased because they've been exposed to it more often, increasingly likely to have this allergy. Wearing latex gloves while providing care can cause that reaction. Like I said, 90% of our gloves are latex free just for that reason. And then to the bottom side of that, the other reason is providers, we found the longer they wear latex gloves over the course of their career, a lot of the times they developed an allergic reaction to it too. So an allergic reaction does not occur the first time it encounters. On the first exposure, the immune system forms the antibodies. So the first time they have it, you don't get the reaction. We don't have the airway problems. It just starts the antibodies. On the second exposure, the antibodies combine with the allergen. This combination releases the histamine, is what gives us in trouble. And this substance leads to the spectrum of reactions. So we've hit on part of these already. Dilation of the blood, which reduces the amount of blood returning to the heart. Flush skin. So when we say flush skin, who do we got? Doug, when I say flush skin, what am I looking at?
Like redness? I don't know.
Yep, redness. So they'll usually have a red skin. Also with it, you'll get heat. Just because when the redness is the blood is coming closer to the surface, so you get that red skin and you'll get heat. Development of the angioedema, fluid moves into the tissue, which causes a swelling. And then when it moves the swelling around the vocal cords, they'll also start to have that inability to speak or difficulty speaking. Oh, come on. So they also get the hives, which is usually the white splotchy spots on their skin, bronchial constriction. So the bronchioles and the trachea, all that starts to thicken up. So you get, instead of a nice 3/4 inch holes, we're down to like a 1/4 inch. And then development of thick mucus in the lungs. It's unpredictable, but normally it gets more severe the more times you get exposed to it. So meaning a severe reaction may be immediate, but it can be delayed with 30 minutes or more. And then mild can rapidly progress to anaphylaxis. Usually the more times you get exposed, the faster you move to that. Closely monitor any patient exposed to a known allergen. Signs and symptoms, we've already hit on that a lot. Skin, so you get that itching, hives, flushed skin, swelling of the face, neck, or hands, tongue. There'll be warm, tingling feeling in the face, chest, feet, and hands. So there's a picture of what you'll see with it. That's the facial swelling. That picture for you guys is a little better. And then you'll get so this is your picture of the hives. So they can be red, or a lot of the times they'll have a white blotchy color to them too. Signs and symptoms that we're going to look for. Respiratory is a big one we're worried about with allergic reaction. You'll have the tightness in the throat or chest, cough, labor, breathing. You'll have that hoarseness, stridor. And then wheezing, most of the time it is audible without a stethoscope. When you walk in, you'll hear them taking that. You'll hear it without any stethoscope to it. Cardiac, why are we seeing an increased heart rate and a decreased blood pressure? What's the body's main way to respond to a drop in blood pressure? Yeah, heart rate.
The heart
Yeah.
pumping faster.
Yep, perfect. The decreased blood pressure, that's the vasodilating that we're seeing. Some general findings, you get itchy, watery eyes, headache, runny nose, and the sense of impending doom. Oftentimes too, with the flushed skin, you'll find it's worse wherever the reaction was. And we'll hit a little more on that. Signs and symptoms of allergic reaction. So you'll have that altered mental status, usually from hypoxia. We talked about the flush, dry, or pale, cool, clammy skin. They're going into shock. So we're seeing all the signs of shock. We'll have the nausea or vomiting, change in vital signs, meaning we have the increased pulse and respiration, and then a decreased blood pressure. So distinguishing anaphylactic from a mild reaction, any previous signs and symptoms can be associated with an allergic reaction. Excuse me, meaning that they could have taken a different medication, walked through grass, whatever it may be that it's starting to cause this too. To be anaphylaxis, this is the big one. The patient must have either respiratory distress or signs and symptoms of shock. So they have to have a difficulty breathing, or they have to show signs of shock, which is the pale, cool, clammy skin, and then a decreased blood pressure. Otherwise, it's just a mild allergic reaction. Treatment of these patients. We're going to perform a primary assessment and care for any immediate threats to your ABCs, open the airway, give them oxygen, whatever we need to that way. During the secondary assessment, we're going to ask about the history of the allergies. What was the patient exposed to? How was the patient exposed to it? Meaning route of exposure. Did it rub your skin? Did you breathe it in? Did you drink it? Did you eat it? How did we get it there? Look for the signs and symptoms, progressions, and interventions, meaning a lot of the times with that is, what have you done? Did you take an EpiPen? Did you wash your hands? Did you get rid of the stinger? Or did you do any of that? Okay. We're going to obtain vital signs and obtain a remainder of the patient history, past medical history. The patient comes in contact, so the suspected allergic reaction when the patient comes in contact with the substance. Patient has the itchy hives, difficulty breathing, and showing signs of shock. So the patient care. So this is what we're going to do about it, right? We're going to manage their airway and breathing, apply high concentration oxygen if they're in distress and appears to be in anaphylaxis. And if they develop that altered mental status, open and maintain the airway is the big one for this. And if they're not breathing adequately, we're going to provide artificial ventilations for them. We're going to take over breathing for them. Determine whether assisting the patient with an epi or auto eject is appropriate. If they're showing signs of shock and they're in respiratory distress, it's appropriate to give them a auto inject EpiPen if they have it. For you guys though, we're going to have to I'm going to back up to one more thing right here though too before we dive into that. Also with the patient care, if they were whatever they're allergic to, get rid of it. So if they had a shirt on and they're allergic to a cat, get rid of the shirt, take a wet washcloth, whatever you can to, and first do a dry and then whatever you can to get rid of the allergen. If it's a bee sting, get the stinger out. If it was a nut allergy, try and do whatever we can to get rid of it. Otherwise, all of the interventions that we're doing from there on do no good because they're just constantly being re-exposed to whatever allergen it is that caused it in the first place. So whatever we can do to get rid of that allergy. All right, back to the auto pen. So for you guys, this is a patient assist medication, meaning they have to have it. So there's some steps on all of these that we have to talk about. So we're going to consult medical control regarding the use of an auto injector when they come in contact with an allergy. Has the respiratory signs of shock, is showing signs of respiratory distress. We've already hit on it, and complains of it too. Oh, they've changed this one on us now. So they are saying now that this used to be you guys couldn't do this unless they had it on their own. But they've changed this now to where you can carry it from the ambulance and use one there. It used to be that was a complete no-no. Cool, we'll take it. So recorded administration of the epi, we'll walk you through how to do these because there's some keys that you have to do. And with some things that if you don't do it, they can pull the auto epi pin out. And once those safeties go back over, there's no way to get that needle to come back out. So this is another skill that we carry or we talk about in class. If the patient meets the criteria for epinephrine, but you cannot carry it, we're going to have to call for ALS intercept. All the self ones. I'm gonna just flip through these guys because this is one we'll cover in class. The only one that we will hit is that you got to make sure you cover your rights. So check the expiration, and it says ensure the liquid is clear. I have yet to see an auto inject pen that you actually see the liquid part of it. But anyway, part of the checks and the rights. After we do it, the big part is after every intervention we do, we have to check and do a reevaluation or reassess. So after we give it 2 minutes. Some things that you will likely see with it, pulse will likely increase. Hopefully the symptoms will decrease though. Epinephrine may be dangerous with a patient with a heart condition or is hypertensive. The only caveat to that though is does it matter if their airway isn't open? If their airway isn't open, I don't care if they were hypertensive and had a heart condition or not, they're dead. So a lot of the times we have to err on the side of the caution or err on the side of opening an airway and give it to them anyway. But it is something to consider with them. Yeah, this traditional thinking held that EMT should only deliver epinephrine to patients with prescribed auto. That's changed. Thank goodness, finally. And I think the other one that you guys will see is Narcan coming to you guys in the next few years. It's long overdue. You guys are smart enough to do this. All of our local agencies allow you guys to give it to. Though the other part we'll add with it too, is if they have it, they may be uncomfortable or afraid of using without help. It's an 18 gauge needle that's about a 3/4 of an inch long. It hurts. And sometimes and it's the same thing. If they don't hold it there long enough, they let the safeties come back over it. So a lot of the times if they understand that, they don't want to be the ones to give it because they also, once it's gone, it's gone. And if you don't get the full effect, then you're still dealing with airway problems. Careful monitoring of these guys is throughout the care. And if the patient condition deteriorates, you may need to give additional doses. Most of the time though, we only carry one auto in the ambulances. So if they have one, bring it with you. The reason why is those auto pens, those EpiPens, like $500. But an ALS, the little vial, which is the same drug, you can get it for $3, and the needle and syringe is another $3. So instead of a $500 EpiPen, we just carry epinephrine and can give it that way. So that's a lot of the reasons why they don't. But you still have to obtain permission from medical control for additional doses along with the initial. Don't confuse that for you guys when you get running outside of this class. Most of these orders, when we talk about, well, you have to call medical control, blah, blah, blah. We have the written orders or the standing orders. So we don't call medical control. I've had a lot of students get like, well, you didn't do it right. Well, yes and no. In the class, that's the way we teach it, but our local protocols dictate otherwise. So don't be confused with that, I guess. AMS agents systems that allow EMTs to use the epinephrine have moved to using the hypodermic needles and syringes. That's the ones that I was just telling you about, just because of cost. And then the other nice thing with it is if we have a cardiac and we run out of the one vial of epinephrine, we can take this and use it for cardiac dose too, with one extra step. So the ready check-in method is commonly used. It's only 1 milliliter of epinephrine carried in a vial or an ampule. Second provider must verify the dose drawn up. For adults, it's 0.3 mil, and for children, it's 0.5 or 0.15 mil. It's intermuscular, and needles and syringe are used. We'll talk a little bit about ampules versus a vial. An ampule, there's one extra step. You snap the glass top off of it, and you have to use a filtered needle to draw it up so that if there's any glass shards in the medication, it doesn't get drawn into the syringe. But we'll go over that in class. The only downside for you guys now, though, is where they've changed this. I promise you, you're going to need to know those 2 doses. So 0.3 mils for an adult, 0.15 mils for a child. 0.15. With great responsibility comes, how's that saying? Anyway, but if they've changed that, you will need to know that dose. The ready check inject method is commonly used. So they're supplied in a single container with a review card. A lot of the times that review card is actually a sticker on the lid. You must be trained to use the kit. It's the same thing though. A lot of the times agencies, if they're in ALS, you'll just find an ampule, a 1 mil vial of epi, and then there'll be a syringe and a needle to draw it up with. Agency must maintain training records of it too. And that goes back to our own protocols. This one, guys, there's a lot of the times with them, it's keeping them calm, removing whatever it is that causes the allergic reaction, transport them. If you have the ability in the service you're running with to give them epinephrine, by all means, give it to them. If not, we've got to get ALS coming to give them that. And it's the same with, we're going to talk about overdoses now. Be prepared to give more than 1 dose. In fact, I've yet to have a really severe allergic reaction where we haven't given at least 2 in my career. Any questions on allergic reactions, guys? All right, give me just a minute and we'll switch over to chapter 24. You guys seen chapter 24 now?
Yeah.
All right, here we go. So infectious diseases, we'll cover that. Sepsis, which is over the last few years has been hit a lot harder in EMS than it ever used to be, because we're seeing some data come out that's proved that we're having success if we're treating it and recognizing it a lot earlier. And then we'll have some selected common communicable diseases. So infectious diseases and how they're spread, we have the two common ones is bacterial or viral. Some other microbes can cause them too, but most of them are either bacterial or viral. Communicable diseases are anything that you have either direct contact with it or contact with the secretions that contain it. This one, over the last year and a half, 2 years with all the COVID stuff, I think a lot of this has been hopefully hammered into our heads a little more than we used to have it, whether it's right, wrong, or otherwise. When infection does not occur or does occur and causes illness, the time from the exposure to the death, well, first symptoms is called the incubation period. I've had a few say that there's been some questions relating to that on the national for whatever reason. The interval when the patient is shedding or releasing infectious is the communicable period, and then when the microbe can be potentially transmitted. So it's incubated and isn't strong, healthy enough that it can be passed now. So some factors causing infection and illness after exposure. So virulence. So this is like the Delta variant versus the normal variant of COVID. It's more virulent. Dose, meaning did somebody cough, touch the table, 20 minutes later, 90% of the bacteria is dead, and then you touch it? Or did somebody cough on the table and you touched it when 90% of it was still alive? So just the amount that you guys had. Route, so usually if it's blood to blood is the best way to transmit it, versus then the next one is if you breathe it or it comes into your tissue, and then or if it comes on just contact with your skin. The skin is a great PPI, meaning that it doesn't allow many bacteria or virus to get through it. Most of the time it either has to be blood to blood or some secretion to, in your mouth to get it. And then body's resistance. And then body's resistance a lot of times this is when we start running into the extremes of age. So if you're younger, 20s, 30s, 40s, a lot of the times your body's fairly resistant to it. If you're in your 70s, 80s, 90s, or 1 to 3 years old, your body hasn't, it's either 1 to 3, it hasn't built up an immune system, or if you're in your 70s and 80s, it's lost its ability to. So the body's less resistant. Any questions on that? So the pathophysiology of sepsis is a life-threatening condition resulting from an abnormal or counterproductive response by the body that causes damage to the tissues. That's a mouthful. Basically, when we talk about sepsis, the body's most of the time it's been sick long enough, so instead of trying to control blood pressure, it dilates everything and then we lose it. There's a slide that goes over to it. It's just an abnormal, and it's not a productive response towards illness, usually because whatever counterproductive response comes because whether it's the liver, the kidneys, whatever, start to shut down, and then we can't fight it as well because of those systems and organs shutting down. And then septic shock occurs when these changes result in shock and hypotension that do not respond to intravenous fluid. Once they go into septic shock, most people actually die from some form of septic shock. It quickly becomes irreversible. So this one we talk about, it has the infection, it's local, the body mounts a normal immune response, usually increased white blood cells. Then we go septic or systemic. The body produces lactic acid and other chemicals. The ability to produce white blood cells may be limited or exhausted, depending on the length of time. And then the body's resistance to it. And then it goes to septic shock, where those accumulate in the bloodstream, causing vasodilation, increased cellular permeability, so they get leaky, and then leads to hypotension. So we move, all that fluid moves from the blood vessels out into the cells, into the tissue, and then there's nothing there for the heart to pump around. So some locations likely to be associated with sepsis. It's usually lungs. So what kills most elderly people is pneumonia that turns into septic shock. Their body just can't handle it anymore. Gastrointestinal tract, especially after abdominal surgery or pancreatitis, ulcers also play into that too. If you've had some really bad bleeding ulcers and stuff like that, they can go septic on you as well. Urinary tract, so kidney and prostate infections, especially if it's a chronic kidney infection or a urinary catheter. And there, it's so long that it's been there so long that the body just can't fight it anymore. What's the other thing you notice with all of those? Are they an internal or an external thing? It's an internal, yeah. So that's why we missed it a lot of the time. We can't see the infection. We can't see the cause, the damage to it. Locations, some other ones, the skin. So if we have an IV that's long-term, tracheotomy and tube. The other one that a lot of people that are in the hospital for quite a long time is pressure sores. There is still much about sepsis that is unknown, but we have some we used to not be as aggressive with it as we are now. When we start treating sepsis now, we're fairly aggressive with it. So some system is inflammatory response syndrome, or SIRS criteria. So temperature lower than 96 or higher than 101, heart rate over 90 or respiratory rate over 20, blood pressure lower than 90, and new onset altered mental status. If we're seeing any of those, we're starting into sepsis. So quick for sepsis related organ failure on SOFA. It resembles that, does not predict whether someone is septic though. Predicts whether though the septic patient will have a longer to stay in the ICU or be more likely to die. So the faster we start to see organs and systems shut down, the less likely, A, they're going to be in the hospital longer, and B, they're more likely to die. So we're going to have to look for signs for sepsis in infected patient. So what are some signs for you guys after going through those slides? What are some signs that we're going to look for? It comes back to those: the temperature, your heart rate, and your blood pressure. Everybody always wants to say blood pressure. The sad part is if we're down the road to the fact that we're seeing it in the change in blood pressure, you're way, way, way behind the 8 ball. We want to try and catch it in those temperature range, or in the heart rate and respirations. So some signs and symptoms we're looking for is the fever, heart rate, respiratory, and blood pressure. And then the new onset mental status. We're going to provide supportive care. If they meet those criteria, we're going to call in a sepsis alert. And all that does is at the hospital, they're going to have respiratory, we're going to have lab work there, we're going to start a fluid challenge, lots of different things with these guys too. The other one that I will add to it now that's really changed over the last 1.5 years, 2 years, is get ALS coming, because we've been instructed to start treating it more aggressively too. So if we can start fluid in the field, start temperature control in the field, it's a lot better. In fact, they're also starting, some agencies are starting to carry antibiotics and some things like that. That's how serious we're getting with sepsis now. 10 years ago, 5 years ago, that would have never been a dream, but you're seeing it in a lot of agencies now. So this is just a few selected common communicable diseases that we have to worry about. So patient care and assessment. Prevention is, an ounce of prevention is worth more than a pound of treatment. So we're going to try and do the appropriate vaccinations, standard precautions. Assessment: has the patient traveled, and then have you received recommended vaccinations? Understand how the patient feels with their care. You're going to want to wear your PPE, get further testing, or receive preventable prophylactic antibiotics. Well, let's hit on a few of these and then we'll go on to some others. So chicken pox is caused by the, I'm not even going to try that, Bacillus zoster virus. Starts with symptoms are vague, resembles a cold, followed by the fever and rash, and it's usually got the itchy and looks like blisters. It is very contagious, has to be direct person-to-person contact, or airborne from rash on the skin or mucous membrane. Dried scabs, though, once they dry and burst, they do not spread the disease anymore. So there's your little kiddo with the chicken pox. Treatment and prevention: isolate the patient until the lesion's dry. Antiviral medications can shorten the course of the disease and prevention. There also is a vaccination for that. Receive vaccine within 3 days of exposure. Most of the time, though, with this one, it just runs its course. And unless their fever gets really, really high, there's not much you're going to do about it. It's just going to have to run its course, treat the fever. Measles, also called rubella, it's a highly infectious viral disease. It starts with the fever. Oh, go back. Cough, eye irritation, the small white or blush white spots on the inside of the cheeks, and then the red blotchy rash. For that one, it's easily spread and held in air droplets, contact with the nose and throat. There's no specific treatment. Same thing, a lot of the times it's just gotta run its course. So vaccination, quarantine, and hand hygiene. So mumps, signs and symptoms, they're usually vague: muscle aches, loss of appetite, and headache, swelling and inflammation of one or both carotids, and last 7 to 10 days. So when they're talking that, that's the down on the bottom of your cheek, those will swell up. You're gonna get that right there. Yeah. So that on the bottom part of your chin. Its transmission, droplets, direct contact with saliva. Prevention, vaccination, quarantine the patient for 5 days after the swelling appears. Same thing, let's manage the fever and the airway with this one. Word of measles and mumps, usually what age group, and chickenpox? What's the common factor in all those? School age kids, so it's usually a young age. Now, when we start talking about hepatitis A, it's a general term that means inflammation of the liver. Won't come out. Signs and symptoms of it, excuse me, guys. Have the fever, nausea, loss of appetite, malice. Malice is just weakness. Abdominal pain, jaundice. A few days later, it's generally worse in older patients. So there's your jaundice. It's the yellowing of the eyes. You'll also see it in their skin color can go a yellow too. Same thing, spread by fecal or oral route. That's the fun part of it, is it's usually a fecal to oral. So hand hygiene, is a big one. Showers, proper food preparation, and then vaccination. Hepatitis B is an infection. It's very common in many parts of the world. You got the nausea, vomiting, loss of appetite, vague abdominal pain, progresses to jaundice. Younger patients may have fewer symptoms to no symptoms, but more likely to develop a chronic infection. This one's transmission is blood or semen. And then the other one is like amniotic, vaginal secretions, and a few other fluids. So it's got to have a fluid to go with it, not just it's not airborne. A lot of the times too, new mothers will be tested for this. If mom has it, a lot of the times they'll either try and do a cesarean or other different ways too, just so they don't expose baby to it. There's no specific treatment. Best for is vaccination, proper decontamination after equipment, especially if we've dealt with fecal matter, which we never do. So anyway, but it really does come down to cleaning. Yeah, that was sarcasm. Clean, wash exposure site with soap and water. See healthcare provider right away, vaccination, and then there's some possible immunoglobulin and injections. Hepatitis C is very common and similar to hepatitis B.
Fun fact about hepatitis B, that if you have celiac disease, oftentimes your vaccination isn't effective. So until you manage your celiac, your hepatitis vaccinations aren't effective either, and you have to go back and go through the series again.
We have a son that has that, so we've got to learn all sorts of fun stuff with that. Same signs and symptoms. This one though, it's a bloodborne through shared needles. Less commonly though through sexual intercourse or childbirth. So a lot of the times we'll see this in people that have drug addictions and are using dirty needles. Several safe medication regimens, but there is no vaccine for that one. The big one for it is standard precautions, proper use and disposal of sharps. That's the one, when after we start an IV or we do anything like that, just make sure that needle gets put in the sharps immediately, so somebody doesn't get stuck by the needle. HIV or AIDS, this used to be the big one we always worried about. It still is by all means, but it's not one of the worst ones that we have. So it initially appears with flu-like symptoms with a few weeks of the infection, fever, sore throat, and fatigue. AIDS is characterized by a opportunistic infection. I'm not even going to try and go over those. So here's a picture of the carapacial sarcomas. You'll get the sores or lesions on your body. So its route: shared needles, unprotected sex between men, any penetrative activity involving blood and semen, and during delivery or breastfeeding from a mother to a newborn. So there's same thing. There's some different things that can go help with it on a newborn. Stop. There are some antiviral medications that reduce and suppress the HIV viral load. Prevention is the only thing that we're going to have to stop that one. Standard precautions, public measures to reduce the shared needle. That's why you'll see a lot of the times in bathrooms and stuff now, there's a sharps container that people can put their needles in. Some areas of the city, like your homeless shelters and stuff, they'll actually offer clean needles and a place for them to dispose of them now, just to try and the shared needles part. Following significant exposure to blood or other bloody fluids, wash the area thoroughly, consult a healthcare provider if you think you've had, and this one has to have a open sore, so it's a blood to blood. So if you have an open sore that was bleeding, got a bunch of their blood on it, they had HIV, you definitely need to see a healthcare provider. PPE on this one is huge. And oftentimes the one that gets left out or forgot is eye protection, and your eyes are easily absorbed, stuff like that. So if you got blood in your eyes and it had HIV, it's easily absorbed through your eyes. So glasses, goggles, PPE, wash. Influenza, it's a common viral illness. There's lots of different viruses that can cause influenza, so that's a general term with it. Signs and symptoms, it's a fever, the non-productive coughs, muscle aches, sore throat, headaches, severe weaknesses. So there's your child showing the sign of a fever. Usually with the child is the viral infection or the fever the bigger danger. The fever. So we got to treat the fever. So it's spread by droplets or direct contact. Antiviral medications lessen the severity, but must be taken within 48 hours of the onset. So hand hygiene, surgical masks. When we say surgical masks, it's usually the N95 or higher, and then vaccination. Croup. I'm not even going to try that. HPVI is what causes it. Signs and symptoms: inflammation, swelling of the larynx. Child between 6 months and 3, they're more susceptible just because their body's immune system isn't that strong. Especially if they're not nursing from mom, they tend to have that. What you will see on the test questions with that, though, with croup, they have a characteristic seal-like barking cough. For whatever reason, they love to throw that one on the basic. So croup has that seal-like barking cough. And it usually gets worse at night. As they're laying, and a lot of the times that's because as they lay down, all that crap gets built up really, really good in their chest, and then it's just hard. They're trying to get rid of it. It's the droplets or coughs or sneezes that survive on objects. So assess your child for any patient for the shortness of breath. Prevention is the hand hygiene, refrain from touching nose, eyes, and mouth. Same thing with this one. We're going to manage the airway. The fever is the big one that we're usually working with, and then your PPE. Pertussis or whooping cough. Signs and symptoms begin like a typical upper respiratory infection, worsen into anaphoric coughing by whooping sounds on inspiration. You guys get on YouTube, and we've only got 20 minutes, so we're not going to have a chance to tonight, but just listen to the different breath sounds. That seal-like bark cough, that whooping cough. They're very distinctive once you've heard it once or twice. Spread by large droplets in the air. Treatments: antibiotics. Prevention with the vaccine. Hand hygiene. Refrain from touching eyes or nose. Pneumonia. Fever, chills, shortness of breath. Tachypnea. What does that mean? Rapid breathing. I can see you over there. I knew what you're saying. Productive cough. They have the inflammation in part of the lungs, so it usually starts in the lower, and the more you have the lung that's involved, the worse it gets. The febrile seizures in young children and infants, and altered mental status in elderly patients. Pneumonia is what kills most elderly patients. So there's your x-ray. You can see on the bottom part of it, here the white kind of cloudy parts on it. Especially, so if you guys are looking at this, it would be the patient's right lung. You can see the pneumonia set up really, really good in it. So all that white, and it looks like blood vessels and stuff, that's infection. That's the airways that are clogged off with junk from the pneumonia. That's what you're seeing it as in the X-ray. It's spread by droplets, but does require close contact for several days. Treatment with antibiotics, preventions, vaccination, hand hygiene, cough, and etiquette. So, yeah, so a lot of the times the body can fight it off if it's resistant to it, and then if it keeps getting hit with it, then it, or if you get, say, somebody coughs right in your face versus somebody coughed on the table and then you touched it 10 minutes later, you're less likely to get it that way, which is what they're talking with the cough etiquette. Tuberculosis, you have that cough, it's initially dry, but it's later have productive or purulent sputum, meaning it's that red frothy sputum that comes with it. So when they cough, whatever rag or whatever has usually got a blood tint to it. Fevers, night sweats, and weight loss. Spread by coughing, singing, or sneezing. So treatments are antibiotics, prevention with vaccination, high suspicion of index. If you think they have it, you want to wear an N95. And this is one that you have to get tested for every 2 years to recertify in the state of Utah. Inflammation or meningitis, so it's an inflation of the meninges caused by a bacteria. So they have an abrupt onset of fever, nausea, vomiting, severe headache, the nuchal rigidity, photophobia, meaning the light, they don't like the light, they usually want just dark, and then the possible petechia. I can't remember if this shows a picture of it. So petechia is the red spots in the eye. The other one you'll see petechia with is choking victims, because it causes the eyes, blood vessels in the eyes to burst. So that's you'll see the red kind of splotchy stuff on their body. That picture's horrible on the projector, sorry. Well, that's what you're seeing with it there. So it's usually a spread by direct contact. Treatment with antibiotics for meningococcal meningitis. Prevention is vaccination. That one's usually a little harder to treat because the meninges are protected with the brain, and so our treatments are a little harder. The other one that we always deal with is your sexually transmitted infections. So your viral, we have HIV, hepatitis A, B, and C, genital herpes. The thing to remember with it is they don't necessarily have to have a giant sword to pass it on. And then the human papillomavirus, your bacterial, chlamydia, gonorrhea, and syphilis, which is the most beautiful word in the English language, believe it or not. Prevention, condoms, vaccination. It's not a common reason why people call 911, other than except for women who develop the pelvic inflammatory disease. That one's usually caused by your bacterial ones, so your gonorrhea and chlamydia. Causes lower abdominal pain, and then may be increased or associated with increased vaginal discharge. Tick bites usually transmit, it's the Lyme disease, not the tick bite, that causes the problem. So they usually have a rash with the bullseye symptom around where the bite was. Treat it with antibiotics, and then prevention in backcountry rescue and wooded areas, especially that are known to have ticks in them. Cover the arms, check frequently for ticks, and then we're going to remove ticks with tweezers. Emerging and newly recognized infectious ones. So COVID-19 obviously is the big one we're talking about now. Usually they're the result of a bacteria resistance. So, and then patients may get infections that no longer are treatable, and because of that, they may die from that disease that would easily be cured a few years ago. So this is where when we're talking about that, that's, somebody will get an antibiotic and not take it like they were supposed to. Take it, they get feeling better, and after, somebody's unmuted. And then after they get feeling good, they stop taking it. And then it's, so the other one too, SARS that we had a few years ago, Ebola, the Middle East respiratory syndromes, the Zika virus. They're all different ones that have come out now. And then the other one that's come out since this is COVID-19. We should go ahead and, I'm not going to say remain calm, understand that news reports may exaggerate the extent, a number, or ease with which the disease is spread. Can we just put this those first two parts on the news like right now so people will calm down? Follow recommendations from the CDC or your local health department. We can leave that one up though. Anyway, and that's it, guys. Any questions on infectious diseases? If not, we're going to call it a night. Like I said, the link that you guys have been using, it expires tonight. We'll get a new one created and emailed out to you guys. If no other questions, you guys have a good night. And if you're working graveyards tonight, I will see you shortly.
See you soon, bud.
Gotta love it.